Hello everyone and welcome to another session of next Saviours Essential Question Series. You see, this topic that is pedal edema is very commonly observed practically, and there should be a habit in diagnosing the cause of the pedal edema because this is something which makes the patient extremely worrisome. So today we are going to discuss how to approach to the diagnosis if the patient is presenting with pedal edema. You see, the key important features that are important for you to recognize are whether the edema is pitting or non-pitting. Obviously, we'll be talking about the mechanics behind it. Second, unilateral or bilateral, because unilaterality or bilaterality of this edema ultimately might provide a hint for you to reach the diagnosis, whether it is because of the systemic or a local cause. Then important history and science in order to reach the final diagnosis, and finally it is confirmed with the investigations. So point number one is to identify whether the patient is having a unilateral or a bilateral pedal edema. So you see, whenever you get a question related to this pedal edema differential diagnosis, then the first thing which will be provided is a progressive swelling in both the feet or a unilateral feet. That means they'll be giving you it as a hint that whether unilateral or bilateral affection is there. Now, why is it important? Because in case if the reasons are bilateral, then these are the systemic reasons. It could be cardiac failure, the renal involvement, the chronic kidney disease, the liver involvement, malnutrition, or even the hypothyroidism. But if the patient is having a unilateral involvement, then it is because of the local reasons, which could be a cellulitis, it could be lymphedema, it could be because of the venous insufficiency or the varicosities of the vein and the deep vein thrombosis. So this gives you a hint that if the patient is having a bilateral involvement, then obviously you have to look for the systemic reasons among the infections, among the options. But if there is a unilateral involvement, then you have to look for the local reasons among the options. Now, after deciding the laterality, the second thing which is extremely important and is kept in the question or in the options are the edema, the type of the edema, whether it is a pitting edema or a non-pitting edema. You see, a pitting edema is because of increased interstitial fluid with decreased or low protein content. As a result of which, what happens? That this kind of the edema, when a pressure is applied, then it can be very easily displaced. So this results in displacement of the edema by the application of the pressure. Now, what are the possible reasons or the mechanisms behind this? The first one obviously is the increased hydrostatic pressure, as happens in case of congestive heart failure because of the edema which gets collected in the interstitial fluid with a decreased protein content. Second reason could be because of the decreased oncotic pressure, as happens in case of nephrotic syndrome or in case of liver failure. Then the third possible reason is increase in the capillary permeability, as it happens in case of inflammation. And finally, it could be because of the increased fluid retention in the body, which happens in case of chronic kidney diseases. Because of these potential causes, what happens that interstitial fluid, it shifts whenever the pressure is applied and there is a formation of a pit. So this is the reason why it is called by the name of pitting edema. The other kind of the edema which can happen is a non-pitting edema. You see, main reason for this non-pitting edema to happen is it is because of the accumulation of the fluid which is bound to tissue matrix or due to cellular infiltrates, which obviously cannot be displaced by pressure. You see, the possible reasons or the mechanism could be because of the increase in the interstitial proteins or mucopolysaccharides, which results in, as happens in case of mixed edema. It could be because of the lymphatic obstruction, as happens in case of lymphedema. It could be because of the increase in the cellular infiltrates or even fibrosis, like happens in case of chronic inflammation. And all these results in the formation of the fluid, which is fixed in place, as a result of which there is no pit when the pressure is applied. So this is the basic mechanism behind non-pitting edema. Now the third very important reasons are the drug intake. You see, every time you get a question, there is always a possibility that some drug which is a potential cause for the formation of this edema at the level of the ankle might be kept as a hint for you to identify. So you should be knowing about that what are the important drugs which are known cause for this edema or the pedal edema. So one of the cause is the calcium channel blockers. You know, amlodipine, the nifedipine. What is the reason behind for causing this edema? Because you know these drugs are responsible for preferential arteriolar dilatation, which results in increase in the hydrostatic pressure. And this increased hydrostatic pressure will result in fluid extravasation. So this is how the calcium channel blockers are responsible for this fluid edema or the pedal edema. Then another one cause is the non-steroidal anti-inflammatory drugs like ibuprofen or diclofenac. Now, what happens that these drugs they are responsible for inhibiting the prostaglandin synthesis, which results in decrease in the renal perfusion and it results in increase in the salt and water retention. So, this is how this increase in the salt and water retention because of decreased renal perfusion is a mechanism by which NSAIDs are responsible for causing the pedal edema. The third one are the steroids like prednisolone. So how prednisolone is contributing to it? As you know that it is responsible for promoting both sodium and water retention via mineralocorticoid activity. And whenever there is a retention of sodium and water, it might result in the edema through the body. Then another set of drug is thiazolidinediones like pioglitazone. The mechanism by which it is responsible for causing pedal edema is that it increases the vascular permeability and thereby it causes renal sodium reabsorption, thereby leading to pedal edema. And finally, the minoxidil, which is a vasodilator, as you already know, that it results in the same mechanism like calcium channel blocker results in the edema is the arteriolar dilatation, resulting in increased reflex sodium retention, thereby increasing the capillary hydrostatic pressure. So these are the important drugs which are known causes for the pedal edema, which are usually kept in your options or in the questions for you to identify. So this was the third segment in reaching the diagnosis for the pedal edema. The first one, obviously, we have talked about that what is the laterality, whether it is unilateral or bilateral. The second one is whether it is pitting edema or non-pitting edema. And the third one, in order to reach the diagnosis, what are the drugs which are potential causes for this pedal edema. Then finally, ultimately, you have to identify that what is the exact cause based on the clinical features. You already know that there are several diseases which might result in the formation of the pedal edema, which could be both systemic as well as local. Now, if at all in the option there is a history provided like the patient is having dyspnea, orthopnea, elevated GVP, basal crepitations, cardiomegaly, and nocturnal cough, you already know that these are the clinical features of the congestive heart failure, which has resulted in the bilateral pedal edema. For nephrotic syndrome, the clinical features would be provided like facial puffiness, frothy urine, proteinuria, fatigue, or the possible ascites in case of nephrotic syndrome. If at all the question is providing you the history of ascites, spider angiomas, the palmar erythema, the jaundice, or the gynecomastia, obviously it all is pointing towards the chronic liver disease, which again is a reason for bilateral pitting edema. In a question, if there is fatigue, there is anemia, there is oliguria, polyuria, elevated urea to creatinine ratio, then it is a feature of chronic kidney disease. For the questions which are providing the history of dry skin, bradycardia, the cold intolerance, weight gain, or hoarseness, you already came to the conclusion that it is all because of hypothyroidism or myxedema. While if there is a thickened skin with a pudy orange appearance, painless recurrent infections, it is a hint provided for lymphedema. Similarly, there are some local causes also, like if there is a history of tender swollen cough with redness, positive Human sign, fever might also be presented to you. These are all the features of the deep vein thrombosis. Rather, on the other hand, if there is a warm, redness, pain, fever, and localized swelling, it could be because of the cellulitis, which is a pre-infective stage for the skin. Now, in case if the question is providing you the history of dilated veins, the skin hyperpigmentation, the varicosities, and the venous ulcers, then these are the features of venous insufficiency. For drug induced, there has to be a specific drug which has to be mentioned. In case of third trimester of the pregnancy, it is all associated with preeclampsia. And if the patient is having this pedal edema, and there is also a possibility that the patient could be having this pedal edema because of the prolonged standing or immobilization. So whatever as a hint is provided to you in the question, on the basis of that, you have to identify that what is the likely reason for this pedal edema. Then finally, the last part of the question is going to be either in the form of the question itself or in the form of the hint that could be provided for the identification of the cause. That what is the most appropriate initial investigation that you have to go for. So what are the investigation? As you already know that for ruling out the cardiac causes, there has to be ECG echo. Similarly, for ruling out the systemic causes like liver disease, chronic kidney disease, there has to be a specific investigation done. in order to reach the final diagnosis. And then finally, what are the general supportive measures for all edema cases? Plus, because in the management, you have to treat the specific cause too. So, if there is a specific reason, then obviously that is the definitive management for the pedal edema. But what are the general supportive measures that you have to take? The first one, obviously, is the salt restriction to less than 2 gram per day, leg elevation in order to aid the venous return, compressive stockings which are useful in venous and lymphatic causes. The weight reduction is particularly important or helpful in case of heart failure and chronic kidney diseases. And fluid restriction has to be done in case of congestive heart failure, chronic kidney disease, or in case of the patient who might be suffering from hyponatremia. So I hope you have understood the topic well. Hope you have learned something new. All the best for your future examinations. Do not want to miss any update. Please join our Telegram group. The link is provided to you in the description.